Our speakers, I'll introduce you both at one time, and I don't know who's going to speak first, but just feel free to come on up.
Sounds good.
So Rae Green, this is her bio. After extensive experience working in residential treatment centers, Rae Green sought a new treatment approach to substance use disorders. Rae founded Sanford Addiction Treatment Centers in collaboration with her husband David to serve as a beacon for recovery and to inspire those with SUDs to achieve richer and more fulfilling lives in long-term recovery. Rae studied history at Alma College, and afterwards she attended the Detroit College of Law for her Juris Doctor degree, but her passion was always helping those with the disease of addiction. She managed several nonprofit organizations prior to receiving her master's degree. Rae worked in a subacute detox unit at the start of her career, and she also spent 5 years at a residential treatment center. There, she was instrumental in collaborating with the clinical team to implement successful treatment models. She has since been certified as an advanced alcohol and drug counselor. Rae has dedicated her working career to chipping away at the shame of addiction. Her goal is to provide education and a comfortable setting in which to heal and rediscover a sense of worthiness. Jenny, is that Selent? Selent. Yep. Jenny Selent is a licensed marriage and family therapist. She received her Master of Science degree from Western Michigan University. Jenny lived and worked in Utah and North Carolina over the past 13 years, but she is thrilled to be back in her home state. She says it brings her closer to her family and allows her to advance mental health treatment in Michigan, which we all know we need, right? Since 2007, Jenny has been doing clinical work and developing residential treatment programs for youth with co-occurring disorders. Most recently, as Executive Clinical Director at Solstice East RTC, she is drawn toward healing and the development of systems. This includes academic, mental health, professional, and family systems. She works to improve the overall health, fulfillment, and effectiveness of these systems and the individuals within them. Jenny has specific training in EMDR, eye movement desensitization and reprocessing, brain spotting, and trauma-focused equine-assisted psychotherapy. She also has a decade of experience in developing therapeutic programs for co-occurring disorders. So it's my pleasure to have you guys get started. So thank you.
Can you guys all hear me okay if I stand like right here? I usually project, and if I start getting excited about material, I project even more. So I might be yelling by the time this is over. Rae and I was just looking up here at the slides thinking, I don't even have like a title slide, which is kind of indicative of what's going on with us right now. We're in the middle of next week. Our subacute detox facility is opening up, and we're about a week away from opening our PhD program for our eating disorder program. So we have a lot going on, and so I could talk about this stuff all day, but there was a little bit of like craziness in putting these slides together for you guys today. So
we'll try to make it up to you in our dazzling personalities.
Absolutely.
So thanks for that introduction, Dara. And in addition to all those academic things that sometimes I forget about, Alma College and history seems like a lifetime ago, my family's also been very profoundly impacted by this disease. So it's not only professional passion, but also a very personal passion as well. And as a part of our program, a couple things. One, we started out to treat clients, and that is our purpose, and to help those who are very sick. And it quickly became apparent that our mission was much greater than that. It was to help not only those who come to us, but it was to incorporate the family systems and families and help to educate them. And also, even a bigger mission, particularly in our state of Michigan, where mental health and behavioral health and substance use disorder is not as evolved as it is in some other states. And so we have that great privilege of being able to work on that. So hence the lack of pretty slide, getting right down to the nitty-gritty of it, is because we are about to do that, open a new additional facility and site that Jenny has almost single-handedly been handling. So I told her tonight on the drive down, I said, I brought a little neck pillow and a blanket, and I said, you sit in this and let me just chauffeur you, because she needs some TLC right now. But you know, trauma is her real expertise, so she's got great information. But just to get started, you know, you can't, we talk about families, and that kudos to each and every one of you in this room tonight, reaching out for supports, for information, for education, either for yourself or to help others in the room. And that goes for those who are struggling themselves, have a family member who is struggling, or who has lost someone to this devastating disease. And that is sometimes, you know, it's as important to understand what went on and to feel that compassion when you have lost someone to this disease, because unlike any other, there can often be that sense of isolation. And so, and I could go on about that, but just, you know, this type of group is exactly what allows us to progress and forge ahead and make the advancements that we are. You know, again, too, it's hard not to acknowledge right now that you know, we're in the midst of a historic wave thanks to this you know, epidemic, you know, the worst that we've seen in modern history, together with, you know, the opioid epidemic and just general mental behavioral health. So with that, I think this is perfect timing to talk about the trauma that goes along not only with the disease, but what a lot of us are experiencing right now in our everyday lives. So anyway, with that said, thank you. We'll answer questions at the end too, but I will hand it over to my Chief Clinical Officer and trauma expert, Jenny. If I pull a chair over and sit, it's only because I'm waiting for a knee replacement, so I'm just going to save my knee power when I move the microphone. So.
Thanks, Jenny. I try to actually be careful not to consider myself an expert on this topic, because neuroscience is constantly evolving, and we're at a very, very rapid pace to help us understand trauma and the impact that trauma has on the brain and the entire system. And so we're constantly in a state of curiosity and learning to try to understand how this impacts all other mental health and behavioral health, and actually physical health as well, because it crosses about every sector of a person's being in terms of how it impacts us. And I didn't really actually come into substance use disorder treatment on sort of a direct path. I came across it because I was treating trauma, and so it made sense, because all of the young women that I was working with, particularly with very severe complex trauma, which we'll talk a little bit about, had really had what I would describe as almost like a relational attachment with substances, and it was really, really intense for them. So therefore we were having to treat the substance use disorder at the same time as the trauma, which we'll talk a little bit more about it. But I'm not going to read through all of these. I'll let you guys kind of look through those. There's 5 different definitions of trauma up there. And the reason I put all of those up there is to highlight that the definition of trauma is really quite broad. It keeps getting actually a little bit broader and a little bit broader. The one that I kind of like the best, that helps me to conceptualize it up there the most, is the idea that it's really about stress that overwhelms an individual's ability to cope. So I use the terms trauma or traumatic stress interchangeably. So like really severe persistent stress causes the same symptoms and really brain dysfunction as like a traumatic event does for an individual. So they're really interchangeable, maybe not in the DSM, but they're really interchangeable as far as I'm concerned as a treater. When we're talking about stress that overwhelms a person's ability to cope, there's so many things that impact what is considered overwhelming to an individual. So things like age, the severity of the experience, the degree of harm, either emotional or physical, a level of agency, meaning the ability or perceived ability to do something. So things like learning differences or nonverbal learning disorder, or some of those kind of things can also impact like a child's ability to perceive a level of agency that might actually be there. They might have an ability to do something, but they don't know and they can't access the understanding of how to do that, or the coping skills or skills in general for how to do that. Some of the other things are like how accustomed an individual is to coping with adversity can also impact whether they perceive it as traumatic or not. And then also, a huge one is the cumulative effect. So what happens is you may have at different times heard different terms like hard trauma or soft trauma. Does that sound familiar to anybody? Or people use the terms like big T, little t trauma. So really what we're talking about, the way I think about it is when people are talking about little t or soft traumas, they're talking about traumatic stress. They're talking about cumulative effect of stress. And when they're talking about big T's or hard traumas, in some ways that almost, in my mind, it makes it sound more important, which I don't think is fair. But they're talking about a singular traumatic event when they're talking about those things. That could be a natural disaster, it could be a sexual assault, it could be some sort of, like you're losing your home in a fire or those kind of things. Now, actually treating traumatic stress or complex trauma is actually more complicated, and the healing process is it's more complex, and it can take longer because there's actually a lot more brain neurobiological healing that has to happen that takes a lot of time for the brain to repair itself as a result of what happens from the traumatic stress. So that's why I like to let people kind of take a look at that and broaden our ideas or thoughts about trauma because there's so many things, and it's really all about perception. It has nothing actually to really a whole lot to do with what actually happened or the facts. It has to do with how it was experienced by the individual. And like I said, so many things can influence that experience.
Can I add something? So sometimes I get my wrong counselor hat on, and I was trained to debate facts and show what facts were actual and what weren't, and that was a big learning pivot for me in getting into this field. Is that it isn't what we define trauma as, but it's how that person perceives it. So that something may feel like that's not a big deal, but because of all the circumstances that Jenny just described, as a therapist, you really need to just allow them to define that trauma as they feel it. So,
I actually had this really incredible young woman that I worked with probably 12 years ago that called me, asked if we could chat, and she had been in treatment with me, and she was older, and she was continuing to work her steps and stuff, and she called and she said, I feel like I need to tell you that I lied about the trauma that I told you that I had experienced, and I was like, I'm glad that you told me, and it seems like that was really important to you to tell me. And she was like, did you know that I was lying? And I had to tell her it didn't matter what I thought. It didn't even matter the facts of what you told me didn't matter. It didn't even actually really influence how I was going to keep moving forward with your treatment plan. The reality was you were in a lot of pain and you had all the symptoms of trauma regardless of what it was, the facts of what caused it. And I think it all made sense to her now in her late 20s, like, oh yes, now this all makes sense. I think she was actually in training to become a therapist. But it's a very, very regular occurrence that the story that's being told
as we were preparing for this presentation, and I came on an article, and they described, we've described what trauma looks like and how it can be defined, but this really spoke to me, and it was a description, and I'm just going to read it off the sheet, but I better put my glasses on. Living in fear, terrified no one will come, yet terrified someone will. No relief, just fear and dread. No sense of control and a profound sense of isolation. This can be the experience of a person with a traumatic story. And the daily struggle to keep trauma-related memories locked down and out of mind is exhausting. And as we go through this discussion about trauma and how it works, if you think about that, it helps me to think what that person that we're treating must be feeling like as we go through the therapeutic process.
So as a treater, I think sort of the classic telltale of trauma is it's a disorder of it's a brain dysfunction. There's been a disruption to the function of the brain, and therefore then all of the symptoms that cascade as a result of that. I want to spend a little bit of time, so I'll watch your guys. I actually get to watch facial expressions today, which I haven't been able to do that in about a year. I'll watch your guys' facial expressions to make sure you're not getting glazed over, because I will start to geek out a little bit on this, on the brain stuff, and it can get a little bit annoying, so I'll try to watch and see if I'm annoying you. If somebody wants to raise their hand,
should have one of those
tell me to move on. Yeah. So, understanding a little bit about the brain is, I think, important in my mind for a couple reasons. Reducing the stigma, because much like substance use disorder, it's a brain disease. So understanding the biology of what happens in the brain can really help us both to build empathy and know how to respond more effectively, and what type of treatment to seek in order to support the people we love or for ourselves. So understanding kind of how the brain forms is sort of key to this. So what you'll see here, the brain was designed to develop in a sequential fashion, right? Some of it happens in utero. We think most of the brain development happens between infancy and age 5, actually, and then at a little bit slower pace through the rest of life. There's some interesting things about, we actually do know some different things about when we have some bursts of neuronal growth at different points in life that we didn't know about before. So we always knew, between ages 2 and 3, there's a huge burst of brain growth, which is why life is very chaotic for a toddler, and impulsive and all kinds of things, and they're picking up new things all the time. That also happens again in the teenage years. Now, we have recently learned it happens again in our 40s, so the promising part, so one thing that might actually explain a little bit of midlife crisis and some of the impulsive issues that happen, for decision making, some of those kind of things. But what it also means is that those are huge, significant times of neuroplasticity. So there's also an incredible opportunity for healing in the right environment during those times of life as well. So environment and how self-care and those kind of things are pretty key during those times, because those bursts happen, and then the brain needs to organize all that growth in those neurons in order then to function well. So basically, talking here, it's going to develop in a sequential cancer. So we're talking about brainstem, midbrain, limbic, cortical systems here. The brainstem is a lot of our automatic stuff. So body temperature, heart rate, blood pressure. The midbrain, arousal, appetite, sleep. And then we're moving up the limbic system and getting more to the motor regulation, emotional reactivity, sexual behavior, and attachment. That's the part of the brain that's really responsible for those things. And then the cortical system, which now actually fully developed until I think now it's like age 26. We've moved it up to age 26. That's where abstract thought, concrete thought, and affiliation. So that's really kind of a lot of the control center, controls a lot of impulses, decision making, rational thinking, abstract thought, and those kind of things happen from the neocortex, which isn't even fully developed until we're 26. And then, if you add in trauma, substance use disorder, they both impact the brain actually really similarly, which is really interesting. So it can cause, if negative experiences are happening, depending on what part of the life they happen at and where the majority of the brain development is happening at that time, can actually cause kind of an overdevelopment of that part of the brain. The problem with that is then it's not putting some of the energy into the higher levels of development. So with trauma, what can happen is you can end up with a overdeveloped sort of brainstem region and an underdeveloped neocortex. And we really need all four. The goal is all four of regions of the brain to be communicating both efficiently and effectively in order for an individual to experience regulation. So that's mood regulation, emotion regulation, relational regulation, all of those things is what I'm talking about. So the brain needs to be, those four regions all need to be organized for these healthy relationships and for the brain to really function effectively. But trauma and substance use disorder both disrupt the brain development. And I'll talk a little bit more about how that happens and what it specifically. But as you can see from what I'm talking about, age of first use significantly impacts brain development. Age of first trauma significantly impacts brain development. And I'm going to turn it over to Rae to talk a little bit about kind of the disease of addiction and how that happens within this context.
So speaking of brain development, there's a statistic out there that this is regarding alcohol, but if nobody took a sip of alcohol until they were the age of 25, that alcoholism would be cut in half. And that's all related to this development of the brain. So I'm going to do my super nutshell neurobiology, because I think to keep what goes on with substance use disorder and understand that in your mind is really important to grasp all this that Jenny is telling us. So when I meet with my clients, and this is probably one of the most empowering groups that I can do, because when they understand what's going on with their brain, they can begin to accept the disease model and accept what's going on in their lives. So if you're looking at that little brain, and I have my own definition of that brain stem and that midbrain, I tell my clients are kind of the caveman of the brain. You know, that's the primal instinct to survive, eat, sleep, procreate. It's also the ultimate threat detection system. But as we mature and develop, our neocortex, which I like to refer to as the executive director, the decision-making, the rational, the conscientiousness, that also evolves and matures and grows. But as substance use disorder progresses, can you hear me just as well if I don't use that? Okay, thank you. So as substance use disorder progresses, what happens is you've got this primal brain, this caveman brain, and then you've got your executive director. And so, I don't know, maybe it's closing time at the bar, and your executive director says, you know what, you've had enough, no more last call an Uber, right? And that system remains a little bit in balance, where the executive director is still in control of the decision making. However, with substances, psychoactive substances, bottom line is they hijack the caveman.
They hijack that caveman and they convince caveman that you need your substance of choice to survive. So when you think of some of the stories, and I get a lot of really creative stories from my clients on how they would hide their substance of choice, in the garage, in an oil can, or here or there. But the reason that is, and it seems crazy, and they're sort of embarrassed about that. But if you think about that caveman analogy, and you were a caveman and you were trying to survive, and you had some little berries in the back of your cave, you're not going to go out and share them. You're going to hide them and keep them to yourself and protect them at all costs for survival. And that, in fact, is the nutshell of substance use disorder, is that there becomes this uber focus on, I need my psychoactive substance to survive. And so when people say, well, how could you, not have made it to the PTA meeting, or how could you have, treated your spouse or your loved one like that? Well, it's because that substance has become the predominant focus, and in effect, the executive director has gone to sleep at the wheel. So what you've got is a raging caveman in control. Now, because there is, the symptoms of this disease, unlike diabetes, where you can't eat a big piece of chocolate cake, or you've got to watch your sugar levels, or heart disease, this disease manifests itself in behavior. And the behavior is what the rest of the world sees and judges. Why would they make that decision? But if you really understand the neurobiology of the disease, it isn't a decision that's being made. The pivot and the turning point that defines substance use disorder is loss of control, that there is no longer that decision to be made. So the age of first use, just as it is with trauma, can have a big impact. Before the age of 21, there is no blood-brain barrier that's been formed. So psychoactive substances have an autobahn, they have a neuro highway to get up to that brain and leave their mark even earlier, and that imprint stronger. So that's my nutshell, and I love that one. I could go on, but I'm not going to, because what I want you to do is to understand that if that is already happening, or if it's prone to happen because of trauma, that you've got this dynamic already. Now, why does, someone might just use, there's lots of why me reasons, it might be genetics, it might be environment, but in the case of trauma, it can be either erasing pain, or, we're not getting into your territory, okay, or it can be filling the gap. Somebody has been neglected or didn't, I'll use that word attachment, but that's more your word than your area. But it can be because that person's baseline is actually lower than someone who had a healthy upbringing. I don't want to use the word normal, but that baseline. So the use of a psychoactive substance can make them feel the attachment. They become attached to the substance, or it makes them feel more normal emotionally. So,
yeah.
Okay.
Yeah, so one way to think about this is what happens with, especially adverse childhood experiences, so earlier trauma, especially if you've had 2 or more, then what happens is that it impacts the production of neurotransmitters and hormones. So the neurotransmitters that aren't developing as a result of trauma are things like dopamine, norepinephrine, and serotonin, and trauma thwarts the development of those things. Those things are responsible for attachment, pleasure, ability to feel love, mood regulation, and things like ability to regulate stress. We need those things for survival. So trauma can actually significantly impact the brain's ability to even produce these things that need to be being produced and growing and transmitting messages from the body to the brain, those kind of things. So then substances come along, and will flood the brain with dopamine. And if you have somebody whose brain is already deprived of the thing that it needs to survive, and then all of a sudden the brain just gets lit up in a way that nothing else can light it up. Relationship, first baby can't light it up that way, sex can't light it up that way, food, there's nothing that can even touch what substances do in terms of lighting up the brain with dopamine. So then the more we use it, then those neurotransmitters actually reduce their sensitivity to the hormones, to being able to take those on. So then over time, what happens is that our overall ability to enjoy pleasure or have anything enjoyable in life decreases so dramatically that then the only thing that can provide any relief for that is substances. Nothing else can touch that deficit anymore. That is the link. That's where the link is. That's why there becomes this survival use link, particularly for those that have experienced trauma, especially early in their life. Questions so far? Yeah.
Why is it that substances create more dopamine than what we can produce? Is it because of the trauma? So we lack it, or?
No, even if you don't have trauma, substances, especially like opioids, those kind of things, they just chemically, that's how they interact with the brain. That's what causes the high.
Yeah, it's kind of like pushing the accelerator down.
Yeah.
You know, that if you walk on a beach and it's beautiful, or you have a relationship, you know, you're kind of going at a nice speed, but you know, that shot of heroin or that Oxycontin or alcohol, it can just pushes that accelerator down to, you know, 100 miles an hour right away.
Yeah. Yeah. So our body starts to not, the more that we're using, then the body starts to reduce its production. And then we're in a really bad place. It takes years for that can take years for it to correct itself. But what's the most dangerous is that there's already a deficit because trauma thwarts the development of those neurotransmitters, as it is. So that's why there's that link between the two of them. I think we can move to the next one. Oh, well, let me just talk, you can move to the next one, but let me just talk about, just as an example, I had this client, and this was pretty normal where I was working in the treatment center I was working with because we specialize in treating trauma. This young woman that was, she was so cool. She was like the kind of kid that like everybody wanted to be her friend in the treatment center. All of the staff loved her. All the other clients wanted to be her best friend. And she probably was the loneliest kid in the room because she could not feel it. She couldn't experience the love that she was surrounded with. She was adopted from Russia at about age 3 or 4. And then she was brought into this home where parents loved her very much, but they had another child that was struggling pretty severely with some symptoms from autism spectrum disorder. And so there was a lot of focus on him, and there was a lot of stress in the house trying to support that and some of the conflict and chaos that would come along with that. So so the groundwork was laid very, very young, and then things just kind of spiraled from there, and there was some sexual assault experiences and those kind of things. By the time she came to me, she really had truly developed an attachment with substances. The things that we experience, maybe when we hold our first child or those kind of things, that's what she would experience when she thought about using. Because there was nothing else that could produce any of those feelings for her. And she was the most motivated client. She wanted to get better. She wanted to change this. But that groundwork was laid so early, it was such an uphill battle for her. And at that point, it wasn't like with 16-year-olds that medication-assisted treatment was really being talked about. It actually probably could have really been a huge support to her once she got to be 18 and she was able to
like I think you had said, you don't really have to know that you've had trauma. Right? I mean, even my son, I was like, there had to be something happen to you. I know, they're trying to find the trauma.
I know.
You gotta know.
Yeah. Yeah.
You have to know what the trauma is. Do you have to realize what that is and then work on it from there?
You
Or
don't.
can you just work on it?
You don't have to. You can use trauma treatment to increase resilience overall. Yeah. Now, there's also biochemical predispositions and vulnerabilities as well, right? So a child can be born with predisposition towards some mental health issues or sensitivities in the world, where a lot of things can be overwhelming. Talk about kids with sensory integration issues. I don't know if you guys know anybody that has sensory integration issues. It's often associated with some autism spectrum issues, but it's a lot of individuals can struggle with sensory integration. They are constantly overwhelmed by stimuli in their environment. And that can be traumatic stress for them. It's not the classic kind of trauma, it's just chronic stress and overwhelm because of constant stimuli that their brain is not able to process and integrate fast enough. So noises, smells, sounds, all of those things can overwhelm their system. And they can never get regulated in back-to-base system. Baseline, unless usually they're going into like a sensory deprivation room where they can, or like Temple Grandin would have created like that squeeze machine or some of those things so that they can just like reduce down all of the senses. But they can't live in that, and so they're constantly then having to go back up and get overstimulated again every time they go out into the world. So there's so many things that can impact this dysregulation for an individual. Living with a mental health issue is traumatic, and especially through identity formation here and trying to understand what's happening, why you might be perceiving things differently than other people, all of those things. Other questions? We're not watching.
Where are we at?
Okay.
We're like not even paying attention. We're just loving being out and talking.
I want to get to the
people.
really hopeful part of the treatment, the really exciting part. I do want to talk about this adaptive continuum. Let me take a minute to explain this first. So what this is talking about, we have these adaptive continuums because we're wired to survive and reproduce. So these are adaptive. They're meant to help us survive and cope, right? So when we're looking at this, what you're going to look at is across the top, you're talking about your mental states. The mental states are calm, alert, alarm, fear, or terror. Those are the mental states. As a stressor is introduced to you in your environment, you will go up the continuum in terms of those mental states, from calm to alert to alarm to fear to terror. Okay? If other information or whatever doesn't come into the environment to tell you you're fine, you're safe. If you're not safe, you'll keep going up. There's two different continuums. There's a hyperarousal continuum and there's the dissociative continuum. We're usually prone to one or the other. Usually men are more likely to be on the hyperarousal continuum, women more likely on the dissociative continuum, but it's not black or white. And you can actually jump from one continuum to the other. Okay, so if our mental state is calm, the regulating brain region is the neocortex. If it's alert, it's the cortex, the limbic system. If our mental state is calm, we're in our neocortex. The type of thought we're capable of is abstract thinking, which is our highest level thinking, and our continuums are at rest. So if you go up to alert, then we're going down to the brainstem, basically. So now cortex, limbic system, concrete. So our thinking becomes a little more concrete, black and white. Sometimes we call that rigid thinking, not very flexible. And then we're either going to be more vigilant, or we're going to start to maybe the behavior is more avoidance. As we get to alarm, you're in the limbic system. Thinking is emotional only. You're either going to see resistance or compliance. Compliance isn't a good thing. We think cooperation comes from the neocortex. Compliance comes from down here. And then fear, you can kind of see how this goes. What happens is what we call mental states. We say states can become traits. our identity and our personality can kind of form around that state of being. So this trait of sort of emotional reactivity can become really persistent for an individual. If they don't have the opportunity to process the information and get back down to baseline. So this is adaptive when the continuum is activated, and then effectively we take in other information. Okay, that snake right there is not a rattlesnake, it's like a garter snake. I'm safe, I'm not going to get hurt, and we come back down to baseline, right? But if we don't come back down to baseline, if we're in this persistent state, then we can get kind of stuck there. Then what happens is, if we're just kind of walking around the world nonstop in a state of alarm, enter any stressor, we go from alarm up to here, instead of going from calm to here. So we see this overreaction to stimuli, basically.
One of the first times that Johnny and I were working on a project together, she came in and we were sitting at my dining room table and she said, "Oh my God, this is my favorite chart. This is my favorite thing." And I've never seen anyone so excited about a chart. I know, she loves that. She loves, this is her baby.
It's
right
really
here, this chart.
obnoxious.
Yeah. But you can see then, you know, if you think back to the midbrain controlling behavior because the executive director's gone to sleep, what the arousal responses are. You know, their fear or terror.
Yeah, I have more weird, nerdy information about this, but I won't bore you with more of it right now. But basically, whatever emotions or state a child persistently might experience, that can then be the foundation of their brain function later in life as their brain develops. Questions about that? So, go ahead. This is just, getting ahead of myself. So, okay, so these are all the things that dysregulation impacts. Cognition and memory. Actually, when our kids would come in with a full psychological evaluation, and after they went through trauma treatment, their IQ would improve from the first time they take an IQ test to later. Their memory would improve. Now, many other symptoms that they might be struggling with that have been misdiagnosed as maybe ADHD or anxiety or mood disorders, we would see fall off of the diagnosis for them. Not with everybody, because some of it, that was part of the issue, right, that made them vulnerable. But oftentimes, relationships and attachments, we already talked about that. Self-esteem, the whole sense of self and worthiness and value in the world, just for existing, is greatly impacted. And it can be either overly inflated, or it can be really disruptive on the negative side of things. So, over or under sense of self-esteem. Physical and mental health, the association of physical issues with those that have adverse childhood experiences is pretty drastic. I'm not a numbers person. I didn't love math. That's why I'm here with therapists. So I don't have all of the statistics, but ACEs can greatly increase chances for emphysema, autoimmune disorders, cancers. The numbers are actually pretty, I wish I had it in my head. I think that with 4 or more adverse childhood experiences on the score, that it's like a 60% increase in those physiological issues later in life. And a lot of this, it helps you understand it if you understand that oxytocin pathways are disrupted, dopamine, serotonin, all of the things that are responsible for all this stuff, attachment, memory, regulation, all of those things are impacted by the brain development.
So oxytocin is known as the cuddle hormone, and that's what new mothers experience when they have their newborns. It's also something that occurs when you pet your dog or your cat. But it also happens, it's also released during group gatherings. So just meeting like this can create the cuddle hormone. Not that we'll all be cuddling or anything at the end of but it does create that sort of thing. So,
This is why these relationships and close, especially close intimate relationships can help promote these hormones. And this is why trauma, the one thing all trauma researchers agree on is that trauma has to be treated with a relationship-based foundation. Relationship is key to the healing process.
Does it matter who the relationship is with?
Not necessarily. So a lot of times they're talking about the relationship with the therapist or other providers, or it also can be, a lot of times when we were working with adolescents, we were training the parents to be the agents of, to become the agents of healing. There's specific principles that you can apply to promote healing for somebody, and that's another whole presentation that I would love to share someday. But there's actually specific principles that can promote this natural brain healing for an individual that has experienced trauma. It's not just loving somebody. It's a specific way of being in relationship with them. Yeah.
Do you think that that's partly, I mean, the programs that these guys are introducing and the 12-step programs and different things like that, and the way that we approach these things and our attitudes towards people with these situations that they're dealing with, or any of us are dealing with, that can also create that oxytocin.
Absolutely.
I love,
Yes.
so you feel connected and that you belong somewhere and you're not
Yeah.
person outside.
The sense of belonging, the relationship, the group, the just being together, all of those things, I think are a huge reason why this is so effective.
It's thought, okay, because of the stigma of this disease of substance use disorder, that's why being with peers with like situations, but really there's a whole another aspect to it. So yes, it's the relational aspect.
This is really just kind of a depiction of those continuum states, right? So this is somebody that's pretty high on the continuum. It's called what we call tunneled senses, not just tunneled vision. For the reason of survival, we have to block out all unnecessary information so that we can just focus on surviving, right? So the only necessary information is this threat and these big teeth right here for somebody. But if they go back down to baseline, if they're able to efficiently get back down to baseline, then they can take in all this other very important information that tells somebody whether they actually are in danger or not, right? Like there's a person right here that's very relaxed with their hands on their hip, there's a chain, there's a cage, all those things. This line is obviously enclosed and it's not a threat. But all of that information, so information about all the people that love them, the great job that you have that is a motivator for not using, all of those things are kind of go away when there's a stressor introduced to somebody who maybe is already living higher on that baseline. They cannot, none of that comes into their conscious awareness at the moment.
It's like, there's no abstract formation of what is the bigger picture here. There's no connection between someone's fear and the numbness they're experiencing and the current situation. So one little side note before we change the slide. This is not related necessarily to the trauma, but when we first opened our treatment center, I felt like that's how the rest of the world was sort of looking at us, because Michigan was not necessarily, friendly to treatment centers. And I wanted to mention, and she's gone now, but one of the people that opened their doors very, very first was Sarah Bono, who understood the system, understood what was going on, and has been a supporter and friend of ours since 2014, and I'm just so excited that she's now part of the Sanford team. I know she's on the advisory board here, so I want to give that shout out to her because she was awfully welcoming and supportive, and of course still is.
All right, let's talk about trauma treatments, because that's the more hopeful part. You probably have all the information you need to know this is a horrible thing to suffer from. Go ahead, Jeff.
I'm hoping it will allow you, there should be a link embedded in that video right there. I wonder if it came through.
If it didn't, I'm just going to have to listen to me instead of David Grant about brain spotting, if that's okay. But these are, there's a lot of different trauma treatments. These are my favorites. Some of them because they're evidence-based, some of them because they just provide relief efficiently for people who've been suffering for a long time. And that's based on my experience with individuals. So, but what you're going to find is that all of these do have an element to them that is very foundationally focused on relationship. It's also about information processing. So it's about helping people move from dysfunctional, stuck information and move it toward an adaptive memory, or an adaptive way of processing that information. So, brain spotting, which, some of the innovative treatments take a little longer to get to Michigan than they do other parts of the world. So it's growing in Michigan. It's really big in some of the other parts of the world. But it's really focused on using the eyes to find where maybe the maladaptive or the dysfunctional information is being stored in the body. It can be anywhere. So I think it's like 60% of our brain is actually, the optic nerve is actually about 60% of, I think about 60% of our brain. It's about 80% of our overall senses. Senses are visual. Don't quote me once again on those numbers. But brain spotting is about finding, what happens is you can work with your client and you'll see dysregulation. Basically, when the brain finds the spot where that memory is held. And if you stay with them in a duly attuned way, which is both relationally attuned and neurobiologically attuned way, you can help your client to process through that information and clear out the stuff that's stuck. Now what happens is sometimes we have processed maybe 90% of an experience, but there's a part that is still dysfunctionally stuck and has not been processed and still being held in a maladaptive way in the brain and impacting how we experience the world. So brain spotting can help that. And sometimes, again, if I have somebody that's experienced a traumatic event, I might be able to help them reduce their symptoms around that, build resilience around that, and reduce triggers that remind them of that event and their response to those triggers in a few sessions with brain spotting. It's more complicated with complex trauma, and it does take a lot longer. But this incorporates a lot of relationship and dual attunement. It requires a highly, highly attuned therapist. What happens is you'll actually, your client might say, whoa, I can feel that right there. That just got a really strong reaction. Or I might physically see they'll start blinking, they'll start twitching. You'll see a cascade of physiological indicators that there's activation, where the activation is held in the body of an individual. This is the one, I also feel like it's tolerated the easiest by individuals with the least kind of side effects afterwards, flashbacks, that kind of stuff that can be pretty debilitating and can be scary for somebody to enter into trauma treatment because of that. And this seems to be, in my experience, tolerated most easily by clients without a lot of symptoms session.
How long does it take the relationship with the therapist and the client to develop that?
It just depends. Yeah, there's so many different factors that impact that. You know, but yeah, there's just so many factors that can influence that. Eye movement desensitization and reprocessing. Actually, brain spotting was developed while David Grand was doing eye movement desensitization and reprocessing, and then realized when he started going slower that he could see what was happening, because this is a bilateral stimulation, eye movement desensitization and reprocessing, where you're focusing on the memory, and then you're doing bilateral stimulation. It doesn't even have to be eye movement. They'll use like bilateral stimulation, like buzzers in your hands or headphones that the sound will go back and forth. But that bilateral movement helps to move that information back and forth between the different parts of the brain so that you can more fully and adaptively process it. It might be where I always do my best processing is when I'm running, which makes sense because of the bilateral stimulation. I get through a lot of stuff when I go for a run. So it makes sense. Also, bilateral movement promotes regulation in general in the brain. So it's a great coping and regulation tool is any sort of bilateral movement, walking, running, biking, I say horseback riding, swimming, music that's rhythmic, anything that's rhythmic can regulate the brain. We would put young women on horses and have them ride to the beat of music, and we would sometimes do EMDR while they were doing it.
Wow, that's a try.
So we would put like the headphones or something on them to get that bilateral stimulation. Their heart rate would sync to the rhythm of the horse, and the horse would naturally match up to the rhythm of the song because of what's called co-regulation. We want to regulate with whatever's like close to us, to that rhythm.
And is this all taking place subconsciously?
I would say it's some of both. There's some conscious awareness of what's going on. The nice thing, like with brain spotting, it can be really nonverbal. Person doesn't have, they just need to let me know if they're okay, and if they want to tell me what they noticed while we're spending time on that brain spot, they can. Some people are very verbal processors, and they want to be like, oh my gosh, I just noticed this, I just noticed this, I have this like tightening in my chest, you know, that kind of thing. But they don't have to for it to be moving along.
But I'm just saying, when you're going through it and you're having the physical, is it just processing even, because it's like saying, I have to pay my chest bill. You know what I mean? Do you take that and you work with it at that point?
Absolutely.
Okay.
Yeah.
So it's not like it's just going through the motion.
Yeah, I will definitely work with just that. Yeah. Sometimes it is very, where it's held is it's very somatic. So it's very much in the body versus maybe verbal memories. Now, interestingly, so with complex trauma, there's nonverbal trauma. When a trauma happens before age 4, there's no verbal memory of that because that's before that part of the brain develops. So it's very somatic for those individuals. It's very much held within the body, and they might not have any conscious memory that they can tell you a story about. Like with the young woman who was adopted, was in an orphanage in Russia. Yeah. Somatic experiencing is similar. It's processing more of like how the body's holding on to that. Trauma-focused equine assisted psychotherapy is another one of those that is starting to make its way up to Michigan. It hasn't fully. So equine assisted psychotherapy is always really mostly talked about like the metaphor of the relationship with the horse. This is different. It specifically uses the relationship with the horse to focus on relationship and regulation. So to work on attachment, that relationship, the relationship with the horse, and to utilize regulation, like physiological, psychological, emotional emotional regulation to create a relationship with the horse. Horses are like traumatized individuals. They actually do have a neocortex, but they're like the ultimate prey animal. They're not predators to anything. They're prey to a lot of things. So they have an overdeveloped brainstem. So they can only be regulated, and they can make the right choice actually because it's the right choice to make, not out of fear, when they feel really safe in relationship because they're herd animals. So when everything's regulated and integrated in that individual, it invites that horse they want to be in relationship, and it's immediate feedback. It's like neurofeedback all of a sudden, like very experiential, and then that kind of helps to actually form that neural pathway more quickly toward the relation. I think I heard the number was, when we're trying to learn something or create a new neural pathway, a new habit, if you're doing it in play or in experience, it only takes like 8 repetitions, where it's like 200 if you're trying to just do it like cognitively. So experiential therapies can really expedite the healing process. And then trauma-focused cognitive behavioral therapy as well. So these are all focused on moving memories that are dysfunctionally stuck toward being adaptively processed and organized in the brain. This does promote physiological healing of the brain. It does promote that. And it can bring people back down to that baseline and can help them get back to baseline. But I want to, when we talk about the neuroscience of it and the neurotransmitters and all of the damage that can be done to the brain, some of that healing can take years. So this really will promote it, but really changing and helping that to all of that to heal does take time. And this is where medication-assisted treatment can save lives and can make that recovery process much easier, because it can really supplement until the brain is able to recover and start to more adequately produce those hormones and neurotransmitters itself, until it recovers on its own. And that's the part that takes time, particularly if use or trauma started very young. And when I talk about medication-assisted treatment, I'm talking about that in a very broad way in terms of psychotropics. And I think it's important to consider that, because it can really improve a person's prognosis if they have suffered from early childhood trauma in particular and early substance use disorder. Yes?
What are some of those medicaid-assisted treatments?
I'll let you talk about that a little bit.
You've got your Suboxone or the methadones. Those are used for opiates. So that when you say medication-assisted treatment or MAT, that's what most people think of, and that is a primary treatment. It's evidence-based. It's one that the Surgeon General in 2016 said this needs to be implemented. But if you think about somebody who's, maybe it's alcohol or even without trauma, the chemistry is going to be off, because it's kind of like if you turn the volume up on a radio, like that's what, when you're using a substance, the volume of that substance in your body is rising, so your body itself stops producing it and it goes down. So there's going to be a gap. So it could be something, just a serotonin uptake medication. And it doesn't mean somebody has to be on it forever. Maybe if there's, also co-occurring mental health, yes. And I always tell people, particularly people who have perceptions of it, I don't want to be on anything. Well, you know what, if you have a car that needs oil, you don't keep driving it without oil or spark plugs, and that's the way the body operates as well. And also that the dopamine not only acts as that energy and all the things that we've been talking about with this, but it also is very important in the healing process of that frontal lobe. So the dopamine will also help to heal that. So if there are medications that either promote that or allow the opportunity, now this would be where if it's an opioid addiction and you're using MAT, it's going to allow the opportunity for the brain to start producing that on its own. But it's a process. Because just as the development of the disease is a process, it takes time. And there's a great article by Dr. Nora Volkov, who's the head of NIDA, and she writes, that for that frontal lobe to start waking up and really to get fully in tune again, 100 days is early. So when you look at history, is my history nerdiness. You think about Dr. Bob and Bill W. And they didn't know why. They didn't have pictures of the brain to tell them. But 90 meetings in 90 days, they knew there was a healing process that went on. But now we have pictures that help us understand that, MRIs and that. So we can see what time it takes. So allowing those medications, whether it's the serotonin uptake, whether it's Suboxone, whether, they all help to allow for that healing process.
Could even be like mood regulation type
Right.
thing. That maybe over time actually maybe it will be tapered off, but that may need to stay on board to supplement because of this disruption.
And mind you, that was a non-medical answer. Like if one of our nurses was here, you would have got a lot of fancy names for things. Yeah, okay.
One of the things that's interesting, I'm going to come to you in just a minute. There are two camps of thought around treating trauma and substance use disorder. There are those that will say you do not treat the trauma until after the substance use disorder is under control. Right. This is my very personal opinion. I am not of that camp. I believe that both can be treated at the same time. And anything that I can do to move that needle toward the baseline is an improvement for both, right? So if it's for the substance use disorder treatment, that can move that baseline, move you toward baseline, let's do it. If I can do a brain spotting session and just move us this far, then let's do it. Anything that's going to promote healing is going to help in the overall recovery process. So to the point that if somebody were to come in, even potentially on substances to my office, that doesn't mean I won't do a brain spotting session with them. That would, if there's some psychosis or something like that going on because of the substance, I won't do that. But maybe I won't be able to make this much progress because of that substance, but I might be able to make this much progress. And that's still progress.
Right, strengthening those neural pathways. And
increasing resilience.
And we've, the exciting and hopeful part about all of this is there's so much research right now. And starting with, long before the Surgeon General's report, but that was really a pivot in 2016, and they had another one that came out 2 years later, and people looking at this from a very scientific way and understanding that to have a standalone substance use disorder addiction program really isn't reality anymore. You have to have that co-occurring treatment in order to be effective. And so our latest facility that Jenny is working so hard on, and for the next 2 weeks for opening, is called Sanford Behavioral Health Campus. So we've gone from substance use disorder, or originally Sanford House Addiction Treatment, to the Behavioral Health Campus. So that's a little bit reflective of, in just that short amount of time, the enormity of change, but which also brings with it hope. So.
Okay.
Is there an age limit where you won't give people medicine for their addiction? Is there, are they too young? That's her age?
I don't know what, in terms of more of the traditional medication-assisted treatment, I'm not sure what providers would say about that. That's a great question.
Yeah, because we're 18 and older, so that's a really good question.
We did not provide that at our Boston facility. But that doesn't mean that there aren't some providers that would feel comfortable with that. They might, or if they're in the pediatric realm and understand more about that.
Is your campus, is that a residential for a long period of time?
It's all the entire continuum of care. So that's one of the things that's exciting about detox is that we'll have, for substance use disorder, we'll have the full continuum. detox, residential, PHP, IOP, and outpatient care so people can be wherever they need to in the continuum. And then we'll have a mood, anxiety, and trauma program and a eating disorder program that will also span the continuum of care.
Because in listening to all this treatment, I don't see how it can be of value if someone just comes in once a week or even twice a week. I mean, to me, they have to be there for 3 months, 6 months, depending on how bad they are.
That's right, depending on how, that's the key, is
Yeah, how far
severity
it's
progressed.
Yeah, so how far it's progressed is really the key in terms of where they should be in the continuum of care and for how long they'll need to continue that. You know, for example, I have a woman that wanted to come to me because she's been in a couple of accidents on her horse. She's fallen off and she gets on her horse now, she freezes up. I could probably actually relieve those symptoms in about 2 sessions for her so she can unfreeze and get regulated on her horse. But that was one singular event for her.
So when we first came in tonight, I overheard a discussion out here on love and pouring on the love. And I attended a conference a few years ago with my husband, and there was this dynamic doctor who spoke, who actually helped write the Parity Act. And he gave an incredible talk, but he ended it by saying, this is the only disease that can heal with love. And while it can be challenging at times, particularly for families, the design of the disease is to push people away so that it can continue to thrive and that. So as hard as it gets, always remember that you just, if you can pour on the love, and that might mean for yourself, for your loved one, but to try to keep that open heart is so critical, just like we talked about with relationships. So.
You know, Michigan has a statute for involuntary treatment of substance abuse, but it's really not used because of a variety of reasons. I'm just wondering, is involuntary treatment of substance abuse effective?
Can you repeat that? I'm sorry,
Yeah.
I didn't hear that in the back.
Go ahead. Oh, yeah.
Michigan has a statute for involuntary treatment of substance abuse. This is not used very often. My question is, if you did use it, is it effective?
Okay.
This is probably more of an opinion question for me. I don't love that, and I don't think it's the most effective way. I also think that if I can get somebody away from substances for a little while, might be able to increase some motivation, and it might save their life. It might be worth a chance if that person is at risk of overdosing tomorrow. You know, then maybe it is worthwhile try. Is it the most effective? You know, we know it's not the most effective.
That might be the most compassionate thing to do, though, for someone. If you know, if you can see it and they can't see it.
And they can't. Sometimes if the lights are not on,
Yeah.
and it takes outside interventions, and I'm not sure exactly what involuntary, because sometimes interventions themselves can feel involuntary, or a court order can feel involuntary, but if it takes that measure then to nudge someone into that place where you can get them sober enough where they can grasp it and it becomes...
As a district judge, I would put people on probation. They didn't want to be on probation. They were tested. Sometimes they relapsed, sometimes they didn't. And I believe, I ran a treatment court also, and I've heard that it doesn't matter whether it's involuntary or not. That the rate of recovery is the same, whether or not the person went into the program voluntarily or they were forced to by the court. So I don't know if it's true.
We've certainly had some people that came in not feeling like it was their choice, and they came in hot.
I was going to say, the counselor then, that's the real job of the counselor, is how do they enter?
They became the most motivated client. You know, it's hard to say. This can be an unpredictable disease at times, but it's worth a chance in my mind. It's definitely life-threatening in a very acute way.
If we we could just zoom back for a minute, because you said some things that were very interesting to me. And so I have two questions. And the first one is, so when I meet someone and interact with them, maybe it's the first time I've known them, and also people I've known for a while, and they're suffering from trauma, whether it's amplified or caused by the substance use. I'm actually interacting with someone who has physical harm. They have an injury, just like if they'd been, hit by a car or something. So this person is physically harmed, they're hurt, and it's just not a mental state then, right? That they're dealing with that.
I should have said this. I'm glad you brought that up, because when we were talking about the different things that can cause basically the same symptoms and the same impact, chronic pain or a physical injury can also be experienced in the body and in the brain as traumatic stress. Some of the young women I treated, it was for medical traumas. So one that at a young age she had a brain tumor that was removed, one that had a bike accident, and so had some chronic pain in her jaw and stuff because of that. These traumas aren't all just emotional.
Thank you. That gives me a broader view of what I'm talking with the folks about. So even then, but I'm not real, like, because of their behaviors, let's say they fell into those behaviors that we were talking about, still yet that person is kind of like, normally, you meet somebody new, you don't automatically know them, but this person there is exhibiting these behaviors, so I really haven't made their acquaintance yet either, right? That person is hiding behind that or hidden behind them, because, is that what I was hearing?
I'm not sure if I fully understand.
Yeah.
But are you describing like basically what the symptoms that you're seeing on the outside, if somebody has experienced trauma, because they're so behavioral, it doesn't really give you an indication of who that person is.
Right.
And their personality
Like a little
structure.
girl from the
Yes, absolutely. Yeah, the symptoms are so behavioral. So somebody with suffering from traumatic symptoms can present as somebody with a personality disorder. And as those symptoms, they get relief from those symptoms, then you may see a really different personality emerge from that.
Thank you.
Yeah.
I was curious about your work with horses and that relationship. Can that also, are there other animals like dogs that you might also find some healing from trauma through that relationship?
Yeah, in a little
If
bit.
it's a good dog.
In a little bit. If it's not causing chronic stress. I have one of those over the wine
I
market.
think I
Yes, but in a little bit different way, because dogs are more, their relationship, they're a little bit more reward focused.
So, and you're not on the dog.
Right, but they still can, that relationship and the loyalty that comes from them can definitely promote some of the hormone and that kind of thing.
Yeah.
The snuggling and all the physical contact and all that stuff promotes brain health. The horses are just different because that relationship is motivated by the sense of safety and that comes through self-regulation.
Okay, so yes, the person that is working with the animal learns to, in order to have that relationship, to regulate their.
Yeah, yeah. I want to go back real quick to your question, because really, I said the trauma symptoms, it's really the dysregulation. The dysregulation is what causes the behaviors to be so kind of chaotic, maybe unempathetic, those kind of things. It's the brain dysregulation that's happening that causes the behavioral symptoms for a person. And that persistent dysregulation is what can make somebody, be sort of maybe misdiagnosed as a narcissist or something like that, or borderline personality or those kind of things. It's really persistent dysregulation.
Can I add a little dog tidbit? So we had a Bernese mountain dog that was, he had a rather traumatic entrance into the world, and we took him on and he became our therapy dog, and he unfortunately passed away last year at age 6 from cancer. But when we published on our website, which you can find it on our sanfordhouse.com, and it's a great, it's called Excursions Magazine, and it's got articles of all sorts from A to Z. But the one that we printed about Santino
it was like the spike, the biggest spike we've had in our website ever. And the comments that came in were, he's the only reason I stayed in treatment. He's the reason I didn't walk out the door. So that's not like real calculated data, but it is.
My son was at Sanford House, and I remember that dog when I took
When you visited, yeah, he was quite special.
And he's
So.
really, yeah, does fit great.
I was going to say, you know, that normally we don't do this, but I have heard so many wonderful things about what you all are doing at Sanford House. So now I know that one of the secret weapons is the dog, or the dog.
It will be horses pretty soon.
Yeah, right.
I like to keep that on the back shelf for our CEO, because he doesn't really love horses. They will be there, he just doesn't know it yet.
I won't tell it.
But I think for the audience sake here, because we don't have really anything like Sanford House on the site, so could you maybe explain what sets Sanford House apart from other treatment facilities, just so the audience kind of has an idea of what you bring to the table that might be different?
I think some of it is that dedication to the co-occurring pieces and treating the whole entire person and meeting people wherever they are at in their treatment and trying to make sure they're in the right place in terms of the type of treatment you're getting, so that commitment to the full continuum of care, no matter what kind of service we're providing, whether it's for mood and anxiety or eating disorder or substance use disorder. You know, I came back I'm from the Midwest, but I came from Michigan, but I came back after treating in other parts of the country for 14 years. And the reason was because I came back because there was finally a treatment facility in Michigan that wanted to take on all the obstacles that Michigan seems to throw at mental health treatment and substance use disorder treatment, and take them on like hardcore. And we're really overcoming some obstacles that nobody else was because of sort of that really progressive, innovative way of thinking about treating people. And so I think that, to me, that's one of the key pieces, is that we're always trying to figure out how to more effectively, more efficiently provide relief and fulfillment and give people an opportunity to experience fulfillment in their lives and take on whatever obstacles it needs to take on. So Sanford is like a private residential treatment facility that also accepts all 15 commercial insurances in the state of Michigan. So
and that
really
is one of the biggest challenges.
trying to make that accessible for the individuals with private insurance that were really the underserved population at the time that Sanford came about, because so many commercial insurances would not provide coverage for substance use disorder treatment.
I really wanted Jenny to answer that one because this is my baby, and I can tend to get a little biased probably and protective. But had we known 8 years ago the challenges in Michigan, it would have felt daunting. I don't think we were completely aware of what those were going to be, and being able to provide effective treatment. Even if you know what that is, to be able to provide it in a system and an environment like we have here in our Mitten state is something that has become our greater mission.
We're trying to provide a treatment center that wants to keep providers, really talented providers, in the state, or attract them back. We've been able to attract a couple of them back from some pretty great states.
That's our expansion, really, was to be able to provide that entire continuum of care, so that you're not just plugging someone in to an existing system. You're saying, where should they be, and what's the appropriate treatment for them at this point. So.
Right. Thank you for that. So you're just commercial insurance right now, right?
Commercial insurance and/or private pay, yes. So we don't participate with community mental health.
Right.
And that isn't, it's not because we don't want to, there's just, it's just a kind of a different,
So Medicaid,
so.
you don't participate in.
Right. Not to say that we won't in the future, but when we first started this, I worked at a CMH provider, and what I saw was people leaving the state to get treatment elsewhere. And that's when I said to my husband, I said, why is this going on? And he actually took a wrong turn one day and found this beautiful 1847 house that we decided to turn into our women's facility, and it was to treat what, at that time, and now there's actual reports put out by Blue Cross Blue Shield, the Alterum report, that the people with commercial insurance are the underserved population in this state, in the state of Michigan. So.
We're leaving the state of Michigan. The eating disorder average leaves the state of Michigan.
So that's our little Sanford. And the whole reason that we got the name Sanford House was that it was Samuel Ransom Sanford who built the 1847 house that we bought. And so we just thought we'd give a little nod to history. It really doesn't have anything to do with, there's no great branding exercise or anything, but we thought Samuel helped build the city, and it was a city founder in Grand Rapids, so we thought we'd give him a nod.
Yeah, I think that that's important because I know oftentimes people are advised to let, if they have like, say a young 20-year-old son or daughter who's needing services, many times they're advised to get them off of their insurance and get them Medicaid because they will get better, longer coverage with Medicaid than they would with their own insurance, which is just like, it makes no sense. So, thank you for what you're doing.
It gets me riled, even just the words that are around all the insurance challenges. Well, we really appreciate all of you sitting for this long. Oh my gosh, this is amazing. Thank you, Sarah, for setting it up. And thank you, Jenny, my trauma expert. And maybe you'll take a nap on the way home.
Maybe I will.
Yeah, maybe you will. That's right. Let your chauffeur drive.
Well,